Good day, doctors. Here is our presentation for Case 2 from Group 4, Team A. Patient is a 55 years old Indian female. Patient experiencing syncopal attack and also severe headache on the right side while working prior to admission. Post-syncopal attack, patient was unable to lift left upper limb and unable to walk. Patient had fever, chest pain, SOB, URTI symptoms, and slurred speech. Patient has history of DM, hypertension, bronchial asthma, and was last admitted to hospital for URTI with bronchospasm and electrolyte imbalance. Patient's current diagnoses are acute stroke with left hemiparesis and also uncontrolled DM. The info stated here are past medical history and past medication histories of patient. Patient claimed to be compliant and knew the indication for each medication taken and when to take them. Patient is diagnosed with acute stroke with left hemiparesis. For subjective evidence, patient reported left side weakness accompanied with headache and giddiness. There was a mild weakness of left limb but normal for right limb. Patient also complained of headache. For objective evidence, patient had a high systolic reading of 147 and CT brain scan shows right thalamic infarct. Patient's BP reading on the 26th of March shows high systolic of 173 and high diastolic of 100 mm mercury. For uncontrolled DM, patient was tachypnic and did not inject insulin mixed in the morning upon admission. Patient also had a spike of random blood sugar level which went down on the next day but still on the high end. Objective evidence are respiratory rate 20 to 24 per minute, random blood sugar reading of 18.6 millimole per liter, and HbA1c level of 9.7%. Next, random blood sugar 22.8 millimole per liter on the 25th and went down to 12.6 millimole per liter on the 26th.
Next, I will proceed to explain the physical examination and lab result interpretation. Firstly, for the blood pressure, upon the admission, the blood pressure was uncontrolled and kept increasing during the admissions. This might due to the withhold of antihypertensive agent, hemodynamic change of blood flow during the stroke attack, sign of infections, and hypokalemia. Next, for the dextrose level, it shows an uncontrolled reading, patient with diabetes mellitus, and it might also due to the generalized stress reaction due to stroke, which might increase the level of stress hormone that can lead to increased dextrose level. For the lymphocyte, it shows a depletion during the admissions and improving throughout the admissions period. This might due to the possible inflammation due to the stroke attack. For the eosinophils, the reading was below than the normal range. This is because there is formation of infarction that shows through the CT scan. For the serum creatinine is declining along the admissions. This is because decreased muscle mass, which represent by unable to lift left upper limb and walk. For the potassium level and phosphate level, both reading are below than the normal range, and this might due to the stroke incidence itself. For the magnesium level, it shows a slightly less than the normal range. This might due to the electrolyte imbalance due to the stroke incidence. For the HDL and LDL, the reading was uncontrolled, and this reading was taken during the patient stopped taking the statin therapy, and the patient is hyperlipidemia. Lastly, for the CRP reading, the level is high, and this indicate the signs of infection. It is also represented through the fever and high temperature. Others parameter did not show any significant changes.
There are a few drug-related problems in this case, including no continuation for atorvastatin calcium. From NICE guideline, it is recommended to continue statin treatment in people with acute stroke while already receiving statins. The suggested regimen would be atorvastatin 80 mg per day. From a trial, atorvastatin has shown benefit for secondary ischemic stroke prevention. Next, paracetamol was not started immediately when patient developed fever. Instead, it is only administered the next day. Suggested to administer 2 tabs of 500 mg paracetamol immediately when patient developed fever. The next drug-related problem would be perindopril 2 mg OD is not appropriate. From CPG management of ischemic stroke guideline, it is recommended to not treat hypertension if systolic blood pressure is lower than 220 or diastolic blood pressure is lower than 120. Besides, the concentration of potassium chloride injection exceeds the maximum limit of 14 milliequivalent per liter. The calculated concentration of the KCl administered to patient is 67.1 milliequivalent per liter, which exceeds the maximum limit of concentration. High concentration of KCl may cause serious adverse effects such as cardiac arrest, arrhythmia. Suggested to inject patient with 1 gram KCl 10% in 400 ml normal saline in 2 hours. Next, medroxyprogesterone acetate tablets should be discontinued as it is contraindicated in patients with stroke history. Suggested treatment for fibroid would be levonorgestrel releasing IUDs. As from the CDC guideline, the advantages outweighs the risks. For pharmaceutical care issue, patient has uncontrolled diabetes mellitus. Suggested to assess patient's adherence on diabetes mellitus medication, insulin use technique, storage of medication and insulin, diet, and also lifestyle. Next, patient's medication should be reviewed during discharge, as previously patient was on medroxyprogesterone acetate and tranexamic acid for fibroid. The use of these two drugs is contraindicated and its concurrent use would increase the risk of thromboembolic events.
These are the current medication list of the patient in the ward. For the management of acute ischemic stroke, I've referred to two major guidelines, which is CPG management of ischemic stroke and also AHA acute management of ischemic stroke. Firstly is the oxygen and airway support. According to recommendation, we have to maintain the patient's oxygen saturation for more than 94%. For this patient, the oxygen saturation was above 98%. Thus, no any supplemental oxygen have to be given to this patient. Moving on to the mobilization, early mobilization is recommended to prevent general and neurological complication. This patient was ambulated on bed on day 2 of admission. Thus, the management is appropriate. Moving on to the blood pressure. Antihypertensive medication is not indicated if the patient's systolic blood pressure is less than 220 or the diastolic blood pressure is less than 120. The patient's systolic and diastolic blood pressure is less than as stated just now. Thus, antihypertensive medication is not needed. However, this patient was on perindopril on 27th of March. Next is the blood glucose. Treat hyperglycemia with insulin if the random blood glucose is more than 11 millimole per liter. This patient was on atropine and also insulated to control her blood glucose. Next, enteral diet should be started within 7 days of admission after an acute stroke. This patient was able to swallow oral medication, thus the patient have no problem in oral intake. For infection, treat with appropriate antibiotics. The patient was having infection presented with fever, high ESR and also high CRP level. So the patient was given IV Augmentin of 1.2 gram. For fever, use antipyretic to control elevated temperatures. The patient was having fever, thus 1 gram of PCM is given for this patient. Lastly is the raise in intracranial pressure. There are two ways to lower the intracranial pressure. First is to hyperventilate the patient, and second is administer of IV mannitol over 20 minutes for every 6 hours. The patient having sign of ICP presented with headache and also raise in blood pressure on 26th of March. However, no any management was given. Thus, we suggest to give IV mannitol of 15 grams for this patient. For reperfusions of ischemic brain, there are two medications suggested. Firstly is the IV ectopase and secondly is the aspirin. This patient was prescribed with cardipine 1-tab OD within 48 hours of stroke onset. Third, the management for reperfusions of ischemic brain was appropriate in this patient. For secondary prevention of ischemic stroke, antiplatelets such as aspirin is recommended. Then antihypertensive treatment, lipid lowering and diabetic control are also the important measurement for the secondary prevention of ischemic stroke.
Next is the management of uncontrolled diabetes. For high random blood glucose, CPG recommended to start with prandial insulin TDS and optimize the dose, followed by adding basal insulin if blood glucose is still not controlled. Article from American Academy of Family Physicians suggested that total daily dose of insulin required for this patient is 24 units. As patient is expected to have normal diet, 12 units of prandial insulin and 12 units basal insulin are recommended. So this patient was initially given actrapid 6 6 unit TDS and increased to 8 unit TDS with the addition of insulatard 12 unit on night. It is then optimized to actrapid 8 unit TDS plus insulatard 14 unit on night. The dose of insulin given to these patients is higher than recommended, but it is appropriate because there's improvement shown on the blood glucose level after increasing the dose of insulin. The target blood glucose range for stroke patient is between 7 to 10 millimole per liter. Tight glycemic control with HbA1c below 6% is important for stroke patients. Therefore, the insulin dose regimen for this patient could be adjusted as needed. Hospital discharge planning are important for diabetic patients as well. It is important to address patient education on the storage and injection technique for insulin and the importance of medication adherence because it is suspected that the patient is not compliant. Next is to reconcile inpatient and outpatient medications, ensure primary care follow-up plans, and to reinforce medication and diabetic diet recommendations.
Next, for monitoring plan, in managing acute stroke or CVE in this patient, aspirin was given to actually prevent the recurrent stroke event. So for efficacy monitoring, just assess for recurrent stroke event, and for safety monitoring, we have to monitor the platelet level since this is actually an antiplatelet drug. Also, we have to monitor the liver profile as this drug is mainly metabolized by the liver, and assess any upper gastrointestinal symptoms and also any arithmetic symptoms. Next, for management of diabetes mellitus, actrapid and insulatard was given to this patient. So for efficacy monitoring, we have to monitor the random blood sugar level to ensure good glycemic control with target of less than 11 millimole per liter of glucose. And for safety, monitor if patient shows any signs of hypoglycemia indicated with blood sugar level of less than 3 millimole per liter, and any signs of diabetic neuropathy, as well as check for the hydration status and potassium level. Okay, for the management of hypertension in patient with stroke or CVA, pyrindropyl 2 mg once daily was given to this patient. So we have to monitor the efficacy by monitoring the blood pressure level. We targeted blood pressure considering that this patient is having diabetes as well, would be 130 per 80 millimeters of mercury. So for safety monitoring of this drug is to just monitor whether patient is having hypotension or any signs of it. And also monitor the liver profile as this drug may increase in bioavailability with hepatic impairment. Next, for the management of hypokalemia, potassium chloride was given to this patient, so we have to monitor the potassium level and make sure that it is within the normal range, which is from 3.5 to 5.0 millimole per liter. And for safety monitoring, we have to assess if there is any skin rashes and monitor sign of hyperkalemia, indicated by potassium level more than 5.0 millimole per liter, and also monitor the urine output. Next, for the management of infection and fever, empirical antibiotics such as augmentin was given to this patient, so we have to monitor the efficacy by looking at the signs of infection such as body temperature and also CRP levels. And for safety monitoring of augmentin is just to monitor any adverse effects of the drugs, such as GI symptoms, for example, diarrhea and nausea, and also monitor any hypersensitivity reaction against these antibiotics, such as Stevens-Johnson syndrome. And for paracetamol, just assess patient's condition through subjective monitoring or objective monitoring, such as body temperature. And for safety, just monitor for any signs of anaphylaxis or hypersensitivity reaction, which is rare but yet important to take note.